CSW with prior experience providing case management and outreach services to homeless adults, and I've been a project evaluator in several SAMHSA grants aimed at expanding behavioral health services to adults experiencing homelessness. And despite the research and policy focus on the mental health of people experiencing homelessness, personality disorders and maladaptive personality traits have really been understudied relative to other behavioral health disorders. And this is significant because up to 1 in 5 people who are experiencing homelessness, or adults, might meet criteria for a personality disorder. And these are often comorbid with other behavioral health conditions and can complicate the treatment of those conditions and degrade quality of life overall. Furthermore, even subclinical impairments in personality functioning can contribute to greater psychosocial impairment. There we go. So the aim of this dissertation then is to sort of broaden our understanding of the interrelationships between personality, psychopathology, and homelessness. I do this through 2 aims. The first looks at people who are diagnosed with a personality disorder and aims to examine sort of demographic, socioeconomic, and behavioral health correlates of homelessness among people with personality disorder. And then the second aim approaches it somewhat differently by looking at people who have experienced past year homelessness, and we're looking to identify specific latent subgroups based on personality characteristics and to explore how those are related to different forms of psychopathology. The dissertation is informed by from a theoretical framework of American pragmatism, which is sort of encapsulated in this William James quote that ideas become true just insofar as they help us to get into satisfactory relation with other parts of our experience. American pragmatism commonly used in social work, but also within psychiatric nosology more generally. It's sort of undergirded by 4 main principles, the first of which is fallibilism, which is human knowledge liable to error, it's open to revision. And then instrumentalism, which was sort of captured in that quote there, where concepts are tools that we use to understand the world in order to act in it in different ways. Pluralism is a commitment of pragmatism in which there might be multiple phenomena might be understood through multiple levels, and you might have certain types of explanations that are mapped onto certain levels of understanding, but do not sort of exhaust the concept. I'll be much more specific with this in the next slides in the conceptual framework and how that looks in the homeless context. And finally, there's the idea of coherentism, which is a theory of justification that concepts become, I guess essentially it's that all of our ideas are up for grabs, but just not all at once. Our ideas have to cohere with what we know and other things that we know. This works on an individual level, and it also works on the level of sort of broadening of scientific understanding as well. We evaluate truth conditions of different claims based on how well they fit within our experiences and what we already know. And so this informs the dissertation. And I need to unpack a few concepts before I go into talk through the methods and the findings here. The first of which is just defining homelessness, which on a superficial level it seems like easy to understand. You know it when you see it sort of thing, but that's not exactly right. In the US, the McKenty-Vento Act defines homelessness as having a lacking of fixed, regular nighttime residence. There's another way of looking at it, which is you're experiencing homelessness if you are lacking the sort of minimum adequacy standard. There are 3 components of this standard. One is having legal tenure to the place that you're staying at. The other is social adequacy. Is it overcrowding? Can you enjoy social relations there? And then the basic physical aspects. Is it up to code? Can you live there safely? If you're lacking in at least 2 of these domains, you might be considered homeless when you don't have access to more stable housing. Homelessness could be further differentiated by chronicity, specifically whether it's short-term or episodic or more chronic homelessness. And there are also important cultural considerations when trying to evaluate homelessness as well. The standard of minimum adequacy might be different by the region within the country, or in the global south, housing conditions might differ from Western Europe, and these are important factors to consider as well. I want to share a little about the demography of homeless adults in the US, especially because this focuses on a US sample. In 2020, I didn't use the 2021 data because the pandemic threw off the count, but there's an annual point-in-time count that estimated a little under 600,000 people are experiencing homelessness on a single night in January in 2020. So still less than 0.2% of the US population, but it's still a considerable number, and close to 40% of people who are homeless were unsheltered, living in places not meant for human habitation. And close to 20% of people experiencing homelessness were chronically homelessness, which in the US definition includes being unhoused for 12 or more months, essentially, or 12 months from 3 or more episodes or 4 more episodes in a 3-year period, and having a disabling physical or behavioral health condition. Historically, African Americans are overrepresented in the homeless population in the US. The prevalence rates vary across the lifespan, and there's important differences in people of sexual minority status and homelessness as well. So there's a lot of variation based on, there's not just one type of person that's homeless is the takeaway. And when you look at personality disorders among the homeless, I mentioned first that's maybe 1 in 20. That comes from several different information sources. There are one older and one more recent systematic review that looks at prevalence, random effects pooled prevalence of 23.1% and then 29.1%. We've seen nationwide surveys of homeless adults conducted in 1999 with close to 12,000 respondents, finding about 22% having meeting criteria for any personality disorder. There's similar rates for males and females who are homeless based on a population-wide survey in Denmark as well. So that's where that number comes from. When we think of how do personality disorders factor into homelessness at all, there's certain different levels that we could look at to try to explain this. One focuses more on structural vulnerabilities that people might experience, whether it's exclusion from labor markets, exclusion from housing markets, the sort of conflict theory sort of ideas that motivate these sorts of macro level explanations that people are not able to access the resources they need. And yet, as useful as these can be, they are somewhat limited because there's a lot of heterogeneity of outcomes. For example, poverty is associated with homelessness. There are many people who experience poverty who will not experience homelessness. So this explanation becomes limited in that way. And so another way of approaching it is to look at psychological vulnerabilities. So you might have like a stress diathesis model in which like a person is experiencing certain psychological vulnerabilities within a particular environment that leads to the sort of outcome of homelessness. This could be substance use, it could be behavioral health concerns, and yet these explanations could be limited too. So in the past 20 years or so, most homeless research has tried to identify the interaction between structural and psychological vulnerabilities that contribute to homelessness. Behavioral health is one of those that is both a social phenomena and a sort of psychological phenomena as well. They might, discrimination from landlords, if you have a behavioral health condition, might lead to more housing inadequacy, for example. There's also another important rationale or level of explanation for homelessness that focuses on human agency, and this ties into the sort of pragmatic framework as well. It's very important. Agency and action are central to pragmatism, and it's important to consider the role of agency in theories of homelessness because people who experience homelessness are active participants in their worlds. They can affect change in their experience, and people don't necessarily experience as phenomena structural vulnerabilities or psychological vulnerabilities. They have other experiences, for example, perhaps choice. And even though people might label certain choices as deviant or problematic, those choices could be still undergirded by a sort of rationality that was the best choice in certain of the range of choices that were possible. So it's also important to consider agency as a factor for explaining homelessness and the choices that people can make that may contribute to that, entering into that experience, or contribute to exiting that situation without blaming people at the same time for their choices. And these probably interact at different levels. We wanted to really underscore the possible role of agency in explaining like why homelessness might manifest in across society because of the focus on personality and personality functioning. These experiences of how we relate to ourselves, either in our stable sense of identity or our sense of self-direction, or how we relate to others in terms of our empathic relations, our more intimate relations, affects our experience of agency and choice. And that there might be difficulties with these that people experience. Where these difficulties in personality functioning arise? Well, there's a sort of explanation that you could look at the interaction between genes and a person's environment that give rise to the expression of different traits, which is a very helpful and useful explanation. At the same time, for psychopathology or behavioral health conditions more broadly, it is difficult to trace a lot of biological causes. This sort of phenomenon is called polygenicity, in which there might be multiple pathways to the same expression of events, of outcomes. So a wide range of different genes could contribute to the expression of the same sorts of traits, especially with personality. So then there's another aspect to keep in mind too, which is with personality, its development over lifetime. When you look at the Diagnostic and Statistical Manual, personality disorders are often described as sort of enduring over time, and yet there's evidence that personality, there could be normal variation in traits across the lifespan, and they could change in response to major life events. They could change to a certain degree in response to clinical intervention, and again, just with normal variation across the lifespan. There have been different trait-based models of personality developed, some of which focus on, a lot of them are 5-factor models. The 5-factor model is typically defined as like normal personality traits, how agreeable, how well we're able to be conscientious, to essentially follow through with different activities that we plan for ourselves, emotional effectivity as well. Then there's the alternative model of for personality disorders in the DSM-5 that was proposed but not adopted with the last iteration. And there are these pathological traits like negative affectivity, detachment, antagonism, disinhibition, or psychoticism that could be understood as really extreme or deficient response or expression of normal personality traits. So there's this relationship between what's considered normal personality and then also what might be considered maladaptive traits. The ICD-10 has something similar, except instead of psychoticism, they have more obsessive-compulsive traits included in their trait-based conceptualization. And more recently, there's a sort of hierarchical taxonomy of psychopathology that aims to integrate both personality traits and psychiatric symptoms into a larger empirically based framework. And so there's certain higher order dimensions like internalizing, externalizing, or thought disorders that have underneath them certain spectra, like internalizing thought disorder, disinhibited externalizing, where we see maybe substance use, or antagonistic externalizing, where we see more antisocial behavior and detachment. So these are sort of more recent models of how personality traits are conceived, oriented. And based on the high-top model, we're looking at how different symptoms co-vary with others. And so the less of a reliance on sort of rigid categories of psychopathology and more open to just seeing how symptoms overlap between diagnoses and trying to order these into the more generic spectra. This is, I think, useful for personality research because of the high comorbidity of personality disorders with other behavioral health disorders, specifically anxiety disorders, mood disorders, substance use and alcohol use disorders, and then also schizophrenia spectrum disorders. And there's variation in prevalence based on the type of personality disorder as well. So anxious, avoidant, or more anxious or fearful personality disorders like obsessive-compulsive personality disorder or dependent or avoidant PD are associated with the higher odds of anxiety disorder compared to the more emotional erratic PDs, for example. So there's variation within that. So this are sort of the concepts that motivated and informed research. And so given where homeless research is presently and where personality research is presently, the research questions I devised were specifically what demographic characteristics, socioeconomic factors, and behavioral health conditions are associated with increased risk of both past year and lifetime homelessness for people with antisocial, borderline, or schizotypal personality disorders, which is that first approach. And then the second approach is answered through the question, like, what are the distinct classes of personality in a nationally representative sample of adults experiencing past year homelessness? So again, mentioned briefly before, the data in the sample for this was the National Epidemiological Survey on Alcohol and Related Conditions, 3 cross-sectional study conducted between 2012 and 13 that had an overall response rate of about 60%, which included over 36,000 unique respondents. However, the sample for the first study included those with any personality disorder, so 5,455 people, 1,500 people with ASPD, 4,000 with borderline personality disorder, and 2,300 with schizotypal personality disorder, were included in several different models. For study 2, the analytic sample included only those with past year homelessness, so 704 people. The point of the survey was to really just take a comprehensive view of the sort of psychiatric epidemiology of the US, specifically non-institutionalized population. So they don't have people who are presently homeless included in the analysis, which we'll talk about as a limitation, but for this homelessness being such a rare event, this is one of the few large nationwide studies that afford us this kind of information in the first place. That's why I wanted to use that sample. So for the measures for study 1, when we're looking at correlates of past year and lifetime homelessness, we include personality disorder to limit the sample. Those were assessed through the Audatus 5, which is a computer-assisted survey based on self-report measures, traits that people could have endorsed at any point over the lifetime. And so these diagnoses are lifetime diagnoses. The main outcome variable is homelessness. Past year is operationalized simply as a single question at any point in the past 12 months, have you been homeless? So we lose some important information about the quality of their experience, but again, there's still some utility in it. And for lifetime homelessness, similar to other studies that have been conducted with NESARC 3 and NESARC 1 and 2 data, we asked if a person had, since the age of 15, been homeless at any point in their life. Demographic characteristics included sex, age, education level, sexuality, marital status, loss of a significant relationship in the past year, race, ethnicity. And then behavioral health variables included both past year and lifetime alcohol and substance use disorders, mood disorders, anxiety disorders, post-traumatic stress, and lifetime suicide. Okay? For the analysis of study 1, we start with the descriptive statistics, and then we conduct several logistic regression models to identify those unique demographic, socioeconomic, and behavioral health characteristics of past year and then lifetime homelessness. And then I looked at area under the receiver operating curve to assess the classification accuracy of each model, to assess essentially model performance and if there's variation in performance by different personality type. For study 2, I included 24 different personality traits that correspond to DSM-5 criteria for antisocial, borderline, and schizotypal personality disorders. People were asked how they felt or acted at different points throughout their adult life. And they were asked to exclude times that where a medical condition or a substance use condition might have influenced their responses. And then, same as with the first study, I included both those lifetime past year behavioral health diagnoses and the same demographic characteristics. That's just an example of the process of going through and looking at the different types of questions that correspond to different personality traits. So for borderline personality, we have the criteria of unstable relationships. We have, have you usually gotten attached to people very quickly? If they said yes to any of these 3 questions, then I rated that criteria as positive. The analysis for study 2, this kind of proceeded in 3 different steps. One was building the clustering model derived from those 24 personality indicator variables. Second was to look at how well the sample is classified according to the optimal model. And then the third was to look at, using multinomial logistic regression, the relationship between these different personality classes to different types of psychopathology. Did they vary? So on. So at the results, looking at correlates of past year and lifetime homelessness. We'll start with past year homelessness, but first overall, there are kind of three main points I want you to take from this. The first of which is that these economic factors were consistently more strongly related to past year and lifetime homelessness than the behavioral health factors. More severe personality impairment indicated by comorbidity of personality disorders was a significant behavioral health correlate in addition to lifetime suicide attempt and lifetime substance use disorder. And these other behavioral health conditions typically did not pan out. So it wasn't, comorbidity more broadly wasn't significant. So some of the primary results for past year homelessness, the demographic factors associated with it, lower odds of past year homelessness if you were identified as female, higher odds of homelessness if you identify as sexual minority status, so because of small sample size included any LGBTQ plus in the same variable. A significant demographic factor was loss of intimate relationship in the past year. Highest 5 times odds of homelessness for people with antisocial personality disorder. Past year legal involvement was significant. And like socioeconomic factors, higher family income was associated with incrementally lower odds of homelessness across personality disorders. For ASPD, if you were fired or laid off in the past year, you had higher odds of homelessness. Lacking insurance was significant for any SPD and BPD. Overwhelming debt was also reporting that was also significantly associated with past year homelessness and receipt of any welfare benefits. So primarily poverty, indicators of poverty, whereas like I said before, lifetime suicide attempt and comorbid BPD were the significant ones. Just for future reference, if we need it, there's the sample characteristics. So broadly, more males in the ASPD group, higher elevated, non-heterosexual in these groups as well. Not a lot of variation by ethnicity, which is interesting given what we know about the general population of homeless adults in the U.S. Breakup, half of people experiencing antisocial personality disorder having a loss of a significant relationship in the past year, and close to 1 in 3 having legal issues in the past year of antisocial. So with socioeconomic factors, the main one to highlight here is close to 70% earning less than $20,000 a year. Close to 3 out of 4 receiving welfare at the time. So, and then looking quickly at the high rates of comorbidity between ASPD and borderline personality, 3 out of every 4 there, and about half of people with ASPD also having schizotypal personality disorder. So we see that pan out in the logistic regression. This is why I tried to summarize those main points in the slide beforehand, because there's a lot of information there. Here's where we see the lower odds of being female here, non-heterosexual here, legal involvement and breakup significant here. And then again, with the economic aspects, see much more of the incremental decrease in odds of homelessness across the board here. With higher family income. And the only thing panning out significant besides lifetime suicide attempt with behavioral health disorders is that comorbid psychiatric condition, or personality disorders. Models perform really well. AUC, if we're getting an AUC of 0.8 or higher, we're in business. These we're doing really well. We're going to see when compared to the lifetime models that it's a little less accurate, but there are some reasons for that we could explore. For lifetime homelessness, we see more demographic variables associated with lifetime homelessness. We still see past year family income significantly associated with it, debt, and receipt of welfare, but not as many of the same economic conditions associated with lifetime homelessness. So we might start to wonder, because we couldn't control the temporal ordering of variables here and we don't know when that lifetime homelessness was experienced, is a lower economic well-being, indicators of lower economic well-being, indicator of the recovery from an episode of homelessness. What will it take to help people to sort of recover financially from that as well? For behavioral health variables, we see more lifetime substance use disorders and co-occurring SPD and still lifetime suicide attempt. So with the sample here, we see still higher proportion of males there. Not a lot of variation by race or ethnicity across models. And then breakup in the past year, we see lower prevalence of this compared to the past year homelessness, which tells us a little bit about the effects of deteriorating social relationships might have on someone's risk for homelessness. And then lifetime legal issues were much higher compared to the past year. Legal issues with ASPD about 65%, about 60% for the other personality disorders. Similarly, we went from 70% earning less than $20,000 a year to about 50%. And then, so we see economic impacts like a little less for the lifetime model point here. We still see high comorbidity of PDs here as well. Much more elevated rates of other behavioral health disorders compared to the general population. And then again, this is why I highlighted those other points in the previous slide, where there's just a lot of information here. But when we look at the odds ratios for the family income, we see still incrementally lower risk the higher income that you earn, but the strength of the association is weaker compared to the past year model. We see, again, here, alcohol use disorder being a significant risk factor for lifetime homelessness for people with borderline personality disorder, but across the board, lifetime substance use disorder is consistently associated with that. And then comorbid ASPD as a risk factor for lifetime homelessness as well. We see a little more variation in ethnicity here as well, but lower odds of homelessness for people who are Hispanic of any race with any personality disorder. And that differs from the general homeless population in the US overall. And so in the first model, when we looked at the performance of it, those AUCs were like 0.9 and above. Close here, 0.84 and above. Still, the models performed really well, but they're just not as good compared to the past year homelessness. And again, I think it has to do with the variation in when the homelessness episode happened in a lot of ways. So looking at different latent subgroups of personality traits, kind of the high-level overview is that there are 4 classes that were derived from the latent class analysis. The high severity personality class was associated with higher risk of all behavioral health conditions, lifetime conditions. So there's a high severity class. There's a class characterized by more risk-taking and impulsive behavior, which had higher risk of lifetime substance use disorders compared to the minimal impairment class. There's that class as well. And then finally, a class characterized by more emotional ability, identity diffusion, and relational instability that had higher odds of, or higher risk of internalizing conditions like mood disorders and anxiety disorders, and also suicide attempt. That's what we're going to see in these results, but how do we get there? And again, I got ahead of myself. But to tell you how these classes broke down, that minimal impairment class, which had really low odds of endorsing any difficulty in personality functioning, 24% of the sample. High levels of all maladaptive traits, 35% of that sample of 704 people. Moderately low levels of any maladaptive traits except for higher impulsivity and norm-violating behavior and risk-taking behavior, about a quarter of the sample. And high levels of emotional lability, relational instability, about 14% of the sample there. Why did I come up with 4 classes? Well, I looked at I decided to run 5 models in advance, and based on sample size and prior research looking at personality classes, and looking at the Bayesian information criteria. If we get lower scores, that's supposed to indicate a better model. However, I also looked at the bootstrap log likelihood p-value, and this tells us this non-significant finding here at 4 cluster solution shows that if we were to have more complex models, it wouldn't necessarily explain the data better. It starts to lack parsimony. So even though there's indication that a 5 cluster model will be fine, I went with a more parsimonious model as well. When selecting that 4-class model, the entropy values were high. Essentially, how well does the model classify the data that was already there. And what was the smallest class size? Is that class with more borderline traits, 14%. And the classification error was adequate. About 5% of cases misclassified disorders. We've developed integrated treatments for co-occurring disorders in that way. I think there's a similar mindset that needs to be, that accounts for variations in personality functioning, how that might contribute to like the therapeutic alliance or different behavioral health outcomes, or really engaging at all into treatment services. So I think from a practice standpoint, it's important to start thinking programmatically about what are the different ways that we could better serve people who are experiencing difficulties in personality functioning. My own personal experience was that, like, leads me to this other belief that there needs to be workforce development to help people to recognize difficulties in personality functioning and to respond to them in ways that continue to nurture the therapeutic relationship, even if it feels difficult, because I think I felt least effective in providing homeless outreach when I would get into a relationship with a person like an outreach relationship where they had more, what we'd say, like cluster B traits or whatever. There was a lot that happened that maybe made them not want to engage, or maybe rely on the outreach worker in a way that wasn't ultimately helpful. And I didn't fully understand that. And even going, learning a lot through masters, but there's so much that you learn in practice. I think having, incorporating that kind of training, maybe either into a master's program or some sort of like postmaster's training that people could engage in ongoing professional development to help assess and recognize these traits and how to appropriately respond.
Thanks, Nathan. Really nice job.
Maya? Yeah. I agree with Brandy. Every time I had a question, you seem to come close to addressing it. There's one area I do have questions about. I think from a clinical standpoint, in your own experience, the results aren't terribly shocking and surprising, but you've identified some very specific traits that co-occur that can lead to homelessness. So I'm curious to kind of extend Brandy's question around interventions. It seems like interventions for homelessness and mental illness are really big. Mm-hmm. Like, the individual placement and the service community treatment, they're really big kinds of interventions. And we lack the laser-focused kinds of interventions that might help address some of the issues that people have with homelessness. So you seem to have really kind of tapped into the impulsivity, the relationship instability, and I'm wondering if there are interventions out there that could be deployed to really laser focus in on those problems. DBT is great, but DBT is also big. Like, are there ways to say, okay, this person is really high on this particular set of traits? Mm-hmm. Can we laser in and focus on social support, social skills training, pro-social, different bits and pieces of other intervention programs that we could deploy to have a more targeted approach to people's issues here? Yeah. If that makes any sense.
No, that makes a lot of sense. And I guess I don't have a sort of comprehensive answer to that for sure. My thought is, yeah, DBT is very big, and there are ways of doing it that are very by the book. I think there's a need to sort of like evaluate adapting those interventions, or are there specific skills within that could really target some of the relational discord that might arise. So I think being more flexible in a DBT approach and targeting specific skill building opportunities to target, I guess, the impulsivity being high, but then also the relational instability, sense of self-direction. And then the other thing would be, this just comes to mind, I don't know if there's something out there, but with substance use conditions, there's like community reinforcement approach, and then there's for the person with the substance use disorder, but there's also that for families and caregivers, like CRAFT is what it's called. Mm-hmm. So the intervention is for the person who loves someone who has a substance use disorder, and it's teaching them how to respond to that. So I wonder if something could be developed that helps, since that past year breakup was such a huge factor for past year homelessness, and we see among those who are homelessness difficulties in relationships, interpersonal relationships. Is there something that could be sort of like CRAFT valid for people who are in relationships with those who are experiencing that. And that could help with, like, on a functioning level. I'm not aware of what's very effective in addressing sort of deficits in empathy. So that I don't know enough about, and that seems to be more difficult. We look at a recent update to like a Cochrane review on treatments for antisocial personality disorder, and still kind of not clear how robust those effects are for interventions for that.
That's my point too. Is that there aren't a lot of interventions for antisocial personality disorder, but are there interventions that could be targeted towards the specific elements of antisocial personality disorder? And I'm thinking a lot of folks with these particular traits often end up in prison settings. They're there for a while, and then they get out, and then homelessness follows very quickly after their release. And could interventions be used and targeted to folks while they're incarcerated to avoid that outcome?
I like that.
So that's an area of future research. I think you did a great job with the piece, but I think that might be something to think about.
Okay, excellent job, Nathan. I think you did great in terms of your dissertation writing and also the presentation. So I do not have any clinical intervention questions, so I will provide a group of related research comments. I don't think these are questions, but it's more about comments for you to think about these topics more in the future and also in your maybe manuscript writing. So I think in terms of your aims here and also the overall scope of the dissertation, I think this is an excellent dissertation. I don't think you have a lot to change. It's a very solid two studies here. So that's the first comment I have. And then in the dissertation, there are a lot of things I really like the definition of homelessness and also some other topics there. So I really like those topics in your dissertation. Now, my main comment about research here and also analysis, it's very strong. So my main comment here is about some theoretical perspective, and also we kind of talked about that in email already. So I just repeat those comments here. Is that the theoretical perspective and some related research design. So you have very strong conceptual framework when you talk about two key concepts here, right? Personality disorder and also homelessness. And then I would like to see, if for your future work, I would like to see the further step when you're trying to build in the connection, substantive connection between these two concepts, right? I do not think you have that specific middle range model when you work on these two concepts. You talk about how we are going to explain personality disorder, and then you talk about how we are going to explain homelessness. But if you can further connect these two concepts in a substantive model, I think that will be the next step for this dissertation. And related to that is that if you check these two aims, for the first aim, you limit your sample to people with homelessness experiences. For the second sample, for the second study, then you opposite your aims here. For the second aim here, you limit your sample to those with homeless experiences here. So that's why you can see that you use very two unique angles here to examine the dynamics between these two concepts. But the next step, I think you can think about allowing both concepts to vary.